This is NNI Bites Big Learnings, a podcast where fellow healthcare professionals converse about the latest on nutrition science. Join us as Joseph Noe and Gianluca Lista share their knowledge and insights on preterm nutrition and brain development.
Hello, welcome to Nestlé Nutrition Institute's special podcast, NNI Bites Big Learnings. I'm your host for today, Joseph Noe. I'm a neonatologist and professor of pediatrics at the University of Florida in the United States. I'm joined by Gianluca Lista from Milan, Italy, and he's also a neonatologist. And I'd like to introduce you to Gianluca.
Good morning. Thank you very much, Joseph. I work as a chief of neonatology in a neonatal intensive care unit at the Vittorio Buzzi Children's Hospital in Milano, Italy, and I'm very excited to talk with you about preterm nutrition and brain development today.
So I have a few questions here, and the first one has to do about prematurity. What about prematurity? How is the incidence of prematurity in the world? And what are some of the major problems, both short and long term, in terms of adverse outcomes that are related to prematurity?
Prematurity accounts about 10% all over the world, and ranging from 6 to 8% in income countries, for example, in West Europe, like in Italy, up to 15%, like happens in low-income countries, like, for example, Asia or Africa. Very early for a birth weight, for example, baby born before 27 weeks, or born with a birth weight less than 1 kilo, has to be considered high-risk infants because they may have problem during the transition from the fetal life to neonatal life, may have respiratory failure due to surfactant deficiency, for example, may have a hemodynamic instability, so they are a risk for brain damage due to intraventricular hemorrhage or periventricular echomalacia, may show feed intolerance, may have great risk for infection disease, a risk for necrotizing enterocolitis, etc. Some of these very fragile baby may die or may be affected by long-term respiratory adverse outcomes, for example, bronchopulmonary dysplasia, or neurological impairment, or axiological growth retardation.
So it's amazing how some of these small babies survive. And I think that the advent of neonatal intensive care, especially in the developing world, has made a big difference in terms of survival of these babies. So problems that we've had in the past, like respiratory distress syndrome, I think that we have made a tremendous amount of progress in terms of helping these babies survive using surfactant and mechanical ventilation. But then when you think about the brains of these babies and see a picture of what a 23, 24-week gestation brain looks like, it just has so much developing to do yet. And so how can we use nutrition to help with this developing brain that is so rapid in its development during this period of time and has so many different nutritional needs that it would be otherwise getting from the mother?
Yes, thanks, Joseph, for this question, because I remember when I began my hospital career in the NICU in the early 1990s. I remember that we were concerned with ensuring the survival of baby at 27 weeks or with a birth weight about 1.5 kilo. I remember that was very difficult to give a chance for these babies. But improving care techniques, as you said before, the use of surfactant, mechanical ventilation, antibiotics, the survival of very premature baby, 24, 25 weeks, with a birth weight less than 700 grams is increased. And we are focused much more not only to guarantee the survival of this baby, but to guarantee a very good quality of life, in particular to preserve the brain damage. And we have understood that nutrition may have an important role in improving both respiratory and also neurological outcomes of this baby, especially a tailored nutrition that have to start just after birth with a balanced and a good, adequate, high caloric intake, adequate protein intake, lipids, and from the collection of data coming from observational study, experimental study, we have understood that a good nutrition and management of this baby starting from the first day of life guarantee an improvement of the respiratory outcomes and also the neurological outcomes in terms of reduction on severe brain damage, reduction of the brain dysmaturity with a better maturation, for example, on the gray matter, gray white matter. And when we compare this baby with when they arrive at term equivalent age. So I think it's very important, the role of nutrition in guarantee a good quality of life.
So what about tailored nutrition? Can you talk a little bit more about tailored nutrition? So you mentioned that before. Is it different when you talk about a 34-week gestation premature versus a 30-week versus a 24-week premature baby? How can we try to tailor nutrition for those particular babies?
And this very fragile baby, the first day of life are very, very crucial, and many of them has to be managed with a total parenteral nutrition with high caloric intake, adequate amount of fluids, protein and lipids. But also for this baby, when it's possible, we start just from the first day of life with a trophy nutrition, with the anti-nutrition, if it's possible with the breast milk, or we start with a specific formula adapted for preterm baby. We generally speak about aggressive nutrition because we have to avoid malnutrition. We have to avoid a loss of water, a loss of weight. So we have to take care the first day of life, in particular, as I said before, for the caloric intake, protein intake, and lipids, generally by intravenous infusion, but we don't forget also a trophy nutrition with a minimal amount of anti-nutrition, generally using breast milk.
So that's very interesting. You bring up breast milk. Can you talk a little bit about breast milk and some of the properties of breast milk that might be very important for some of these premature babies, and what makes breast milk different from other forms of feeding?
Yes, breastfeeding has not only biological advantages, but also relational ones. I think that it's very important to promote breastfeeding because allows an improvement in the relationship between mommy and baby. It increases the maternal bonding, increase the educational capacity of the mommy. And human milk is the most complete and natural feeding for newborns. We know from the literature that exclusively breastfed infants have an overall increase in myelin content at 2 years age. And this big amount of myelin content persists throughout the childhood when they are compared to exclusively formula-fed infants. Exclusively breastfed infants had better brain development, on brain MRI, for example, we have found that there is an increase of the volume of the cerebellum, increase the volume of the amygdala, the hippocampus. So the effect of breast feeding is fundamental for the brain maturation, in particular also for the microstructural matter organization with higher IQ performance. As you know, Joseph, the breast milk is full of HMOs, no? That are the third most abundant breastfeeding components after lactose and lipids, and they are not digestible carbohydrates. There are three families of these HMOs. Do you remember? Are the non-fucosylated, fucosylated, and the sialylated HMOs. And we know that the HMOs are important, for example, to reduce the risk of infection disease, and they are involved also in neurocognitive development. And many of these benefits are present not only in how mother's milk, but are present also in donated milk. The problem is that also the milk of your mommy or the milk that we collected from the bank not always are able to guarantee all the caloric intake, the normal amount of proteins that are needed for the baby to grow, to guarantee a normal brain development. This is the reason why we generally use the breast milk fortifications, and we use the multi-component fortifiers that are collecting from the cow's milk. And we know that using this breast milk fortifier, we can guarantee a better axiological growth of the baby. We don't understand exactly if a routine fortification can guarantee a good neurodevelopmental outcome. Further study are needed to confirm this hypothesis.
Are there some components of the milk that may be helpful in terms of interacting with the microbes in the gastrointestinal tract? Just to give you one example, you mentioned the HMOs, but the HMOs by themselves may be somewhat helpful, but they are most helpful if you have bifidobacteria or a certain type of bifidobacteria that helps break those HMOs into smaller fragments. The HMOs are not digested and absorbed by the human intestine, but they are broken down by the microbes, and then those breakdown products may be very helpful. So I guess that's the type of thing that I was getting at with that question. There are certain kinds of microbes, and there's a lot of controversy right now about adding probiotics to babies, and I think that is this something that you might want to comment on?
The best way is to allow the baby to be managed with the human milk that contains both probiotics and prebiotics. But in the future, only further research can conclude if it's better to give both the elements, probiotics and prebiotics, only one of these. I think that we need further research about this topic, but it's very, very intriguing.
Yeah, I think that this is such a challenging area. We both have been involved with this for many years, and I think that we are just still at the beginning of our process of learning about how to best nourish these preterm infants. And one of the things that strikes me is how different they are from one another. And so we are now saving these babies that are less than 24 weeks gestation, but those babies are very different than, for example, a 34-week premature baby. So we can't have this concept that one size fits all. So we have this huge challenge in front of us. Can you comment on that and how we might be able to meet that challenge?
This is a very good question, because one size does not fit all for mechanical ventilation, antibiotic therapy, and also for nutrition. I think that this is the big challenge for the future, because how the gynecologists are able to guarantee the survival of fetuses is very, very complicated. And our challenge could be a tailored approach for nutrition, for mechanical ventilation, antibiotic therapy. I think that is not easy. A tailored approach for the neurological point of view, respiratory point of view, nutritional point of view. And it's important to combine all the intervention, because it's not possible to be careful about the respiratory approach and not for the nutrition. You have to combine all the skills.
And so lastly, could you provide some personal experiences that might provide the participants here with some idea of where we might be going, and how we might be able to apply some of our current knowledge to provide some more personalized nutrition for these babies?
In my unit, every year we admitted about 50 to 60 very low birth weight infants with a mean gestational age generally less than 30 weeks. These babies are twins or UGR, babies with congenital malformation, respiratory failure, etc. So they could be considered high-risk infants. I think that one important approach is a tailored nutrition. And for this reason, I have organized a specific team in my unit composed by nurses, doctors, students, and dietitians, for example. And we take care an adequate and tailored parental nutrition at the beginning and the enteral nutrition. We try to use breast milk. If breast milk of the mommy is not available, we have a bank for the human milk in our hospital. We are prone to fortify this breast milk, and from 2-3 years we have began a tailored fortification of the breast milk, and we generally monitor the effect of this fortification by collecting blood samples every 2 weeks, and so we measure the bone, also the calcium, phosphorus, and the serum alkaline phosphatase, in order to have a tailored approach for the fortification. And also we measure the Zeta score in order to have an appropriate recording of the axiological growth. And we adjust our fortification according to this measurement. We want to compare the effect of this tailored fortification with an historical population that was not managed with a tailored fortification, but with a standard fortification. And we want to compare the axiological growth of these two populations, and also the different brain volumes at the brain MRI that we perform at January when this baby reached the term equivalent age. I hope in the future to confirm that a tailored approach with a tailored fortification may be useful to improve the neurological outcomes of this baby in terms of brain development and also in terms of neurological performance.
Thank you, Gianluca. That's a very important area, and I congratulate you for doing that work. I think that this is certainly something that we need to study further, and there are approaches such as the one you are using, and then perhaps even in the future we might be able to apply some artificial intelligence types of approaches to instead of being retroactive, looking at growth curves, looking at BUNs, looking at what is going on in the baby, but actually be able to predict which babies are at highest risk and how we can intervene before these some of these changes occur. So I think that we are certainly on the right track, and the work that you're doing is very, very important in that regard. Thank you very much.
Thank you.
And that concludes today's episode. Thank you for joining us with Joseph Noe and Gianluca Lista as we talked about preterm nutrition and brain development. We hope you enjoyed and learned from this quick discussion, fellow experts. Till the next episode.